Good evening, everyone. I welcome everyone today for the NCSI webinar series on EEG. So, we had our last session on basics of EEG by Dr. Dhritiman, and today we have with us Dr. Vivek Baru, who is a senior consultant in neurology and who specializes in epilepsy from Artemis Hospital, Gurgaon. He is going to teach us on clinical application of EEG in ICU. Before we go over to Dr. Vivek, I would hand over to Dr. Dhritiman, who is Associate Professor in the Department of Neuroanesthesia and Neurocritical Care, NIMHANS, who took us in the last session of Basics of EEG to just give us an introduction of how we are going to take forward in today's session. Dhritiman, sir, you are up.
Okay. Good evening, everybody. So last time in the basics of EEG, we had covered the physiological basis of EEG, the physiological basis of the EEG frequencies from desynchronization to synchronization, and how that happens. We covered a bit about the quantitative EEG. We didn't go very deep into it, but we covered a bit of it. We also covered the instrumentation regarding electrodes and how all the processing happens inside. So from that on, we missed out on the clinical aspects because frankly, we didn't have the time. So today, Dr. Vivek will take the clinical aspects of EEG, specifically from the point of view of neurocritical care ICU. Over to you, Dr. Vivek.
Good evening, everyone. Thanks a lot, Bharat sir, Ditman sir, Ashish ma'am, and Saurabh sir for giving me this opportunity. So today I will be discussing about the clinical application of the EEG in ICU, wherein I will be discussing many cases which we commonly see in our neuro ICU, and I will be discussing the related EEG findings in detail. So coming to the indications of the EEG in the ICU. So most commonly we do EEG when we have the patient with unexplained altered mental status, where we are unable to find the cause. We have done the blood workup, metabolically say the patient is fine. We did MRI also. We are unable to find the cause, and then we do EEG. Look for NCSE, non-convulsive status epilepticus, or if the patient is having recurrent electrographic seizures without clinical manifestations. Sometimes patient with stroke also comes. They come and the deficit which is having is out of proportion to what is expected from the stroke. In those cases, also we do EEG to look for that patient may be having NCSC along with the stroke. I will discussing one case also related to that. We regularly do EEG in the case of trachea status epilepticus when we give the like anesthetic infusion in which we target seizure suppression, both clinical as well as electrographic, and then we aim for burst suppression in which we target the interburst interval of anywhere between 4 to 10 seconds, and then usually we maintain it for 24 hours. The guidelines say like you should maintain it for 12 to 36 hours depending on the condition. Then, based on the EG finding, you can grade encephalopathy into mild, moderate, or severe based on whether what is the predominant background frequency, whether the posterior dominant rhythm is present or not, whether the state changes are there or not, whether reactivity is there or not. So, coming mild is as the name says, that is the most minimum of the encephalopathy, and severe, and then more than severe is suppressed. When you see the total flat line, you are not seeing an activity, as in the case of electrocerebral inactivity or electrocerebral silence. Some of the EEG patterns can help you in prognostication also, like if you are seeing burst suppression or electrocerebral inactivity, where you know that it is a very malignant pattern and the outcome is going to be very poor, and then in those cases you can prognosticate also.
So Dr. Vivek, one minute. Before you continue, I think another speaker is there near you, which is causing a little bit of echo and interference. If you can like shut off the sound of that speaker as well as mute it, that would be useful.
Sure, sir. Sure, sir. Now it's okay, sir?
Perfect. Good.
Okay, sir. So coming to my first case, so he was recently admitted to us with the history of status epilepticus. He is a 77-year-old gentleman, diabetic, hypertensive, had a recent CHF. Before coming to the hospital, he had CHF for which he was admitted 2 weeks before and found to have low ejection fraction. This time he came to our ER with the history of status epilepticus. It started with the left focal, followed by secondary bilateral clonic seizures, and duration was around 20 minutes. It went on for 20 minutes. When he was received in the ER, he was actively convulsing. and vitals were okay. He was tachypneic. Respiratory rates were 34 per minute. Saturation on room air was 85%, and RBS was okay. So when we received him the ER, he was actively convulsing. So after airways, we did airway management, and we gave him midazolam 5 mg, but that didn't abort the seizures. Again, we have to give it 5 mg after 1 minute. But the seizure continued, so we had to give the loading dose of 20 milligram per kg of levetiracetam. In spite of that, seizure continued. Then we gave valproate also at 20 milligram per kg. And patient had low GCS and he was aspirating, pooling secretion, so he was electively intubated. We managed to get the MRI in the ER itself. He had a history of, sorry, I forgot to tell, he had a history of right ICH, which was 3 years back. So we can see the encephalomalacia gliosis over the right subcortical middle frontal gyrus. There was no active acute finding in the MRI. There was no contrast enhancements also. So we thought that it was because of the scar which is causing the seizures. We connected him to the EEG. So this is the EEG graph which we connected in the ER itself. This is a bipolar longitudinal montage: right temporal, left temporal, right parasagittal and left parasagittal. So here you can see, this is a 1 second bar, the yellow bar. It's not very clear. I'm sorry for that, but this is a 1 second bar. So in every second, you can see some broad phase reversal happening over the F4, C4, C4, P4 region. And this is the 1 second. In 1 second, you will see 1 to 2 activities. So going by that, in the 10 second, if you count it in a total 10 second, you will get somewhere around 10 to more than 10 discharges, but less than 25 discharges, because it is like 1 to 2 per second. So it is fulfilling the criteria of IIC. So what is IIC? IIC is ictal interictal continuum. That means it is more than interictal discharges, but less than ictal discharge. You cannot call this patient as a having electrographic seizures at this moment, and you need to be very aggressive. You need to keep monitoring. The same finding in the average montage. This is the common average montage. So you can see the frequent sharp waves arising from the right temporo-occipital, center-parieto-temporo-occipital region. In the 1 second, 1 to 2 discharges are there. But we continued monitoring, and we saw that the discharge frequency begin to increase. So in the 1 second, 1 to 2, you can see the poly spiking also. The poly spiking and the frequency has also increased. Now it is like 2 to 3 per second. So if we count it in the 10 second, obviously it will be more than 25 discharges. So when more than 25 discharges are there over the 10 second, then it becomes electrographic seizures. Earlier it was IIC, ictal interictal continuum. So it began to increase only even after giving the drugs, even after receiving 2 times of midazolam, valproate, 20 milligram per kg followed by 10 milligram per kg, levetiracetam 20 milligram per kg followed by 10 milligram per kg. His seizure continued. So because of the continuous seizure, so he fulfilled the criteria of refractory status epilepticus. So why it is refractory status epilepticus? Because he has already failed midazolam and one of the anti-seizure medication. But in this case, we used 2 of the anti-seizure medication, that is levetiracetam and valproate. We didn't use lacosamide in this patient because the patient had a history of cardiac CHF. So we wanted to avoid that. So we had to start on midage infusion. So midage infusion started with after giving a loading dose of 0.2 milligram per kg bolus, followed by a start with 0.2 milligram per kg per hour. Sorry, the image is little bit faint. This is the left temporal, left parasagittal, right temporal and right parasagittal. You can see the sharp wave activities coming from the right side only, where I saw you the scar. So this is the point when we started him on the midage infusion. Then we increased the midage infusion because we are not very happy with this. And we increase the dose until we got a burst suppression pattern. So here you can see around 4 seconds there is no activity. Then there is some burst of activity which is not very malignant looking. It is a very dull activity. The amplitude is less than 125 microvolt, which is the target of the burst. And interval is somewhere around 4 seconds. That's when we stopped increasing the dose of midazolam, and we maintained the same doses over for next 18 hours. Then we started tapering over the next 24 hours. Coming to case number 2. So she is a 48-year-old female, previously healthy with no comorbid state. She had a history of fever with loose stool 10 days back before coming to the hospital. on the day of the admission, she had one episode of electronic clonic seizures, which was preceded by the oral automatism, and it lasted for 5 minutes. So, and when she came to the hospital in the ER, she was confused. She was conscious, but she was not obeying our command and disoriented. And there was no neck rigidity. So, coming with the history of fever and nuanced seizures with altered sensorium, provisional diagnosis of acute encephalitic syndrome was kept. And we did CE-MRI brain, contrast enhanced MRI brain, which showed bilateral flare hyperintensities left more than right. I will show the MRI images in the next slide. After doing the MRI, we did CSF studies, which showed 25 cells, all lymphocytic, and protein glucose and lactate were normal. We did biofilm meningitis panel, which showed HSV PCR was positive. I will show you the image also. So you can see this is the flare image, this is the T2 image. You can see the hyperintensities over the left insular, left peritrigonal, bilateral cingulate, right also, but left is more than right. And the same finding on the T2 flare also. And it was showing faint enhancement on the contrast. Coming to the EEG, so we did EEG. This is again bipolar longitudinal montage, left over the right. This is the left parasagittal, then right parasagittal, left temporal, right temporal. You can see some activities over the left temporal as well as right temporal. So you can see these activities are periodic. Why periodic? Because the discharges which are occurring, they are of uniform morphology. If you see this, they are relatively uniform. It need not to be 100% uniform, because it is produced by the human body brain, it is not produced by the machine. And the interval between them, this interval between them, they are almost constant. And similarly, you can see the same activity over the right temporal also, which is more sharp as compared to the left temporal. And again, this is uniform morphology over the left on the right side, and this is more sharp. And and one thing you should notice that both are asynchronous. It is occurring first on the left side, then on the right side. So they are occurring independent of each other. They are independently occurring. They are of different morphology. So this we can call it as a bilateral independent plate, bilateral independent periodic discharge. Same finding in the average montage. You can see the over the right side it is more sharp. Over the left side it is again asynchronous and less sharp. And the inter discharge interval is around 1.5 seconds. So it is called short interval periodic discharges. Same finding in the average montage. Again, same thing. This is one pictorial representation. This slide I took it from the ACNS, American Clinical Neurophysiological Society. The paper was published in 2021, in which they describe the various terms related to the critical care EEG. And I recommend every one of you should have a look on it. It is they have described very nicely all the EEG pattern related to the ICU. Again, in this also they have shown that the bilateral independent periodic discharges, in which the discharges over the left side and right side, they are asynchronous and occurring independently, like similar to our case. So we continued monitoring for that case, our case. So we can see some, this is the, again, right temporal. We can see some evolving activity arising from the right temporal. Started somewhere maybe here. You can see some rhythmic activity, and it is delta activity. Why delta? Because it is 3 Hz activity, which is evolving. And I will show you the next slide. Same finding over over the common average montage. And this evolving activity became they evolve in morphology. They became more sharp looking as compared to the first page. And this is the 8 seconds. So it has lasted for more than 10 seconds. And the same finding in the average montage, you can see that in the later part it has become more sharp as compared to before. So it has evolution. It has lasted for more than 10 seconds. So it is electrographic seizures. So what is electrographic seizures? So for electrographic seizures, you have to have epileptiform discharges, which is averaging more than 2.5 Hz for greater than 10 seconds. So in the first graph, when I showed the IIC, when I told that it is IIC, like in this graph, I told that it is less than 25 discharges over the 10 seconds. So it was IIC. But here, when the discharge frequency increased, it is definitely more than 25 discharges in 10 seconds. So that's why I told it as a IIC, electrographic seizure, sorry. So for electrographic seizure, it has to last more than 10 seconds and more than 25 days, more than 10 seconds and more than 25 discharges. If the same finding, electrographic seizures, it continue for 10 continuous minutes, 10 or more minutes, then it becomes electrographic status epilepticus. Or if we do a 1 hour recording and 20% or more of the record is showing the same finding, then again you can call it as a electrographic status epilepticus. If with this discharges we have time lock clinical correlate, like during that discharge the patient is aphasic or has a time locked myoclonic jerks or like eye deviation to the one side, then it becomes electroclinical seizures because there is clinical manifestation also. And if this thing continues for more than 10 minutes, then it will become electroclinical status epilepticus. This is the another case. So he is a 72-year-old male. He came with history of acute onset disorientation, and he was not obeying, and he was just micturating. He was not following command. Suddenly it happened. So he came in to our ER. So we did MRI stroke protocol that showed acute hematoma over right temporo-occipital region. This is the diffusion weighted image. You can see the hypo intensity, and this is this SWI image. You can see the booming artifact. So, but we were not happy. We were not like it was not fitting in the clinical picture of the MRA. So we did MRI. Sorry, we did EEG. So again, this is the bipolar longitudinal montage. This is the left parasagittal, right parasagittal, left temporal, and right temporal. You can notice from here, from the right parieto temporal occipital region, some evolving activity which is starting in the P402 and T602. You can see some rhythmic delta activity with superimposed spiking activity. I will show you the next page. This has evolved further with anterior spread. Now it has spread to the T602 and C4P4 electrode also. Now it has become more spiky and increase in frequency. So it is showing evolution in morphology, in the frequency as well as location. And again, it has lasted for more than 10 seconds. So that patient, the patient whose MRI just now I showed you, was having clinical manifestation because of the frequent electrographic seizures coming from this area. He was practically in NCSC. So we started anti-epileptic drugs. Fortunately, he didn't require any anesthetic infusion. He was controlled on 3 anti-epileptic drugs only, and he got better, very better, the 2 days after coming to the hospital, and then he was discharged. This is another case. She is 42-year-old female. She was all fine. Suddenly, when she woke up one day, and then she became altered. Altered as in कि she started saying कि मैं बिल्कुल ठीक हूँ, मुझे कोई problem नहीं है. Whatever will be asked, तो भगवान के दया से सब कुछ ठीक है. She will keep doing that. And then we did MRI with contrast. First, we did blood investigation that didn't show anything. Then we did MRI with contrast. I will show that in next slide. That showed ring enhancing lesion over the left temporal region, and the flare image we saw a lot of edema. So again we did EEG. In the EEG you can see this is again bipolar longitudinal montage, left over the right. You can see over the left parieto occipital and temporal occipital region continuous discharges are there. So many discharges, or 5-6 discharges in 1 second. So over the 10 seconds will be 50 or more discharges. So she was again in the last non-convulsive seizures. She was having non-convulsive seizures and she was like aphasic. And this is one video. So first we gave her midage infusion, then we gave levetiracetam, but she was unable to comprehend. Then after giving lacosamide, we took one video.
संगीता जी,
संगीता,
आपका पूरा नाम बताइए.
कोई दिक्कत ना है,
पूरा नाम.
भगवान के दया से बहुत अच्छा है.
So she was like that only. Whatever will be asked, she will like कोई दिक्कत नहीं है, भगवान के दया से अच्छा है. This was even after giving midazolam, levetiracetam and lacosamide. Then we increased the dose, and she again became better next day itself after increasing the anti-epileptic dose, and she didn't require any anesthetic infusion, and she got better. And we start Dexa also because she had a lot of edema around the left temporal region, and that aphasia and electrography. And we repeated the EEG finding next day. It got normal totally. So coming to clinical suspicion of NCSC. What is NCSC? It is non-convulsive status epilepticus. So when do you suspect? First of all, you should have a clinical suspicion. Then you do EEG. NCSC can always be diagnosed with EEG. You need to have EEG to diagnose NCSC. So if if the electrographic seizures are lasting more than 10 seconds, or any pattern which is showing evolution, like I saw few of the EEG graphs before, and they showed evolution. They had lasted for more than 10 seconds. They showed evolution in frequency also. I showed you location also and morphology also. So they were electrographic seizures in the correct clinical context. Then you can diagnose NCSC. But the case like I showed you in the IIC, that is ictal interictal continuum, when the frequency is less than 2.5 hertz, but more than 1 hertz, or frequency is zero point 0.5 or more hertz, or less than or equal to 1 hertz, but has superimposed sharp activity or fast activity. Those activities are called IIC. What is IIC? IIC is ictal interictal continuum. So it is somewhere between the ictal and interictal. You should not never neglect it. Never neglect it. So such cases should be given IV ASM trial. In the ASM trial, you can give either benzodiazepine or you can give other anti-seizure medication. You can give levetiracetam, lacosamide, valproate, or brevacetame, or alternatively, you can give midazolam or lorazepam also. And then you have to check for EEG and clinical improvement. In the clinical improvement, what you can check, like suppose your aphasic was just now I showed you the video, and if after giving the anti-seizure medication that aphasia, if it improves and EEG gets better, then you can diagnose as NCSC. And there is a criteria also I will show you in the next slide. Then you can diagnose the patient as having NCSC. This is again the this schematic representation. This I took it from the ACNS paper, which was published in 2021. I will recommend everyone to have look on it. They are just showing that in a 10 second they have 26 discharges. So it is more than 25, right? So it becomes electrographic series. What is IIC? Just now I told that frequency is less than 2.5 hertz, but more than 1 hertz. Or if the frequency is more than 0.5 hertz and less than 1 hertz, but has some plus modifier. So what could be the plus modifier? That if these activities, purely discharge or short wave, has superimposed fast activity, then it is called plus modifier. That means it has got more epileptiform activity, or any lateralized rhythmic delta activity, which is more than 1 hertz, and with a plus modifier. Plus modifier means superimposed fast activity. It becomes IIC, and for those cases you have to do the challenge test. I will tell you how to do that. So whenever the clinical diagnosis of NCSC is there and EEG is showing IIC, IIC is ictal continuum, which is also called as possible electrographic seizures. So you can give either benzodiazepine or non-benzodiazepine. If the patient has already altered mental status or has respiratory depression, then you should preferably choose non-benzodiazepine drugs. In the non-benzodiazepine, you can use levetiracetam, valproate, lacosamide, brevacetame. Alternatively, you can use fosphenytoin also. If none of these drugs are available, you can use phenytoin and phenobarbital also. So after giving these drugs, you have to wait for 15 minutes to see for improvement in the both clinical status as well as EEG. If there is no improvement, so then you can wait. So in the dose, no, you have to give 2/3 to 3/4 of the loading doses initially, and you should wait for 15 minutes and you should check for the response. If the patient has tolerated it well but there is no improvement, then you can give the remaining of the 1/4 or 1/3 dose again after 15 minutes, and then again you should check. If the patient has not improved, then you can switch to the benzodiazepine. And if you have done the benzodiazepine trial, in the benzodiazepine trial, you have to evaluate every 2 to 3 minutes. And if the patient is not improving, then you can switch to non-benzodiazepine trial. Then you have to look for clinical as well as EEG improvement. So just as I told that if the patient was earlier aphasic, but now after giving the drugs, there is no aphasia, then you will see, then you can call it as improvement. We have a very good scale which is called NCSC response scale, which I will be showing in the next slide. If there is even 1 point improvement, then also you can tell it as a clinical improvement. And what will be the improvement in the EEG? So suppose the patient was having a encephalopathic pattern, was having theta activity, and now you have given this IVSM or benzodiazepine. Now you are able to see the spindles which you were unable to see earlier. Or if the interictal continuum, like that discharges which has disappeared for at least for 1 minute, then you can call it as a positive EEG response. So these are the 4 anti-epileptics, preferred anti-epileptic. Fosphenytoin and phenobarbital can be used if none of the 4 drugs are available. So the maximum loaded dose that's given here, you have to give 2/3 to 3/4 initially, wait for 15 minutes. If no improvement, then again you can give the remainder of the doses. Similarly, for benzodiazepine, midazolam is preferred for lorazepam for challenge. Why? Because midazolam has got faster onset of action, as well as the onset of action is fast and effect is short lasting, so that patient won't become drowsy much. And you have to give 1 mg, and every 2 to 3 minutes you can give 1 mg till you have reached the 5 mg. So how do you check the EEG response to ASM? So as I told that if the previously absent background was absent and after giving ASM, and when you have given ASM, you are seeing normal activity in the EEG. That is one response. And if the EEG is showing IIC and it is showing in the 100% of the record, and you have given the IV ASM, now you are able to produce a break of IIC at least for one continuous minute. Then it is called as a positive response. If EEG is showing naturally occurring break also in the IIC, then the breaks should be after giving the IV ASM, the breaks should be at least 3 times. Suppose if in this graph, the patient had a maximum gap of 15 minutes in the IIC. So to call it as an improvement after giving ISM, the break should be at least 45 minutes, 3 times the max, 3 times the normal limit. This is the NCSC response scale. This is the objective scale which you can do bedside. This is a very simple scale. This you can do even in intubated patient. So even after giving anti-seizure medication, if there is 1 point improvement also, then you will count as a clinical improvement. Like see level 1, there was no response to the painful stimuli after giving the anti-seizure medication. If you are given like suppose levetiracetam, 2/3 of the doses, and you wait for 15 minutes. After 15 minutes, you see that patient is able to localize the painful stimuli, then you will call it as an improvement. Or if you have given midazolam 1 mg, and after like 3 minutes you are saying that now you are giving painful stimuli, the patient is able to now localize pain, then you will count it as an improvement. Now coming to the triphasic encephalopathy, which this is very commonly we see in our neuro ICU or medical ICU also. This is a very recent picture which I took recently. This is a patient. She is a case of COPD, admitted in the ward with type 2 respiratory failure. That then patient suddenly became more drowsy, and then neurology call was sent. And first of all, we were very sure that she is having metabolic encephalopathy. So before doing MRI, we asked for to do EBG to look for type 2 respiratory failure, to look for CO2 narcosis. We did EEG also. So here we can see the EEG is showing triphasic waves. Why I am saying triphasic? Because it has got 3 phases. This is one phase, this is another phase, and this is the third phase. In this, one is the negative phase. Up is negative, down is positive. For triphasic wave, you have to have 3 phases: negative, positive, and negative. And the amplitude of the positive phase will be maximum. That one should remember. And the duration is subsequently like duration of this one is lesser than this one, and maximum duration will be of the third phase, and the maximum amplitude will be of the positive phase, and it will be most prominently seen in the frontal electrode. Like here we can see this is the left frontal, this is the right frontal, and this is the sometimes if you would like to describe this, so you can describe it as a GPD, generalized periodic discharge with triphasic morphology, but you should not confuse it with as a NCSC. I will tell you in the next slide how to do that. Again, the triphasic wave, you can see a nice triphasic wave having maximum amplitude of the positive phases. This is a very good paper which was published in Epilepsia, where a patient with CJD, you may be also seeing CJD or any metabolic encephalopathy, they can be misdiagnosed as having NCSC, and you are giving IV anesthetic drugs, which may not be required. And how to do that, I will tell you. So how do you establish that the triphasic waves or generalized fluid discharge are not ictal? So even in this case, if you give the midazolam infusion or lorazepam infusion, what you will see that all the discharges disappear. But that discharges are not disappearing because of anti-epileptic effect. They are disappearing because of the induction of the sleep. And if you again give the painful stimuli to the patient, those discharges will reoccur. So if the patient, you see that the triphasic waves are there and those are disappearing in the sleep, that is one pointer that it may not be ictal, and you need not to be very aggressive. And if you are able to do like stimulation and you are able to provoke that triphasic wave discharges, then you are very sure that this is not ictal and this is metabolic only. You need not to worry about that. You need to correct only metabolic factors. Again, one patient with triphasic encephalopathy, I will show you that in the sleep you can see the triphasic wave which were very florid, that disappeared. You can see no triphasic waves. So that itself suggests that it was not ictal. So she is the patient for which we got a call. She was having generalized tremor kind of thing, and she was confused also because of narcosis. And then we did EEG, and then we asked now, we spoke with the medicine people that this is not ictal, and this thing. This is again the schematic representation of the generalized periodic discharge of the patient with triphasic morphology. So very commonly we see a lot of like involuntary movements in the ICU, and we get a call that the patient is having seizures. In most of them, most of those movements, involuntary movements, are not seizures actually. So this is a very nice paper which was published in Epilepsy. This is freely available. You can download also. So in this, they found that in that 52% when they were evaluated for the involuntary movement, 75% of them were not having seizures actually, and most of those movements were tremor-like movement or shivering or like semi-purposeful movement. This is one new pattern, extreme delta burst pattern. All of us must have seen before also. This is very commonly seen with the case of autoimmune encephalitis. This is our patient. She is a doctor actually. She had NMDA receptor encephalitis and she was having refractory dyskinesia. So you can see some burst-like activity. You can see that this is delta activity, and on the top of delta you can see some fast activity like burst-like, like toothbrush-like. That's why it is called extreme delta burst activity. You can see that this fast activity, and this fast activity should not be a part of background. You can see on the background there is no, that fast activity is only present where there is delta wave. Sorry, the picture is not good, but the brush was very obvious in this picture. And she is the patient. She was having very refractory this oral movement. So we did very long EEG monitoring, but we never got EEG correlate only. So we treated on the line of dystonia, and then eventually this patient had to be given Botox injection to control this dyskinetic movement. These were not again epileptic movement. So how do we describe periodic discharges? So as I told that for periodic discharges, you need to have two things. One is the morphology of the discharges which is occurring. They should be of the uniform morphology, and the inter-discharge interval between them should be constant. And earlier they used to be called as PLEDs, periodic lateralized discharge. But the discharges need not to be epileptiform. And delta wave, here it is a delta wave, right? Delta wave which is occurring very periodically. So now they have dropped the E term. So now they are called as LPDs, lateralized periodic discharges. Yeah, earlier you used to call it as GPED, generalized periodic epileptiform discharge. But nowadays they are called as GPDs, generalized periodic discharges. So you can see on the both sides they are synchronous discharges of the similar morphology of almost and with the constant inter-discharge interval. This is only on the one side, that is why lateralized. This is very common. You must all of us have seen this kind of EEG. So you can appreciate there is a generalized pure discharge again of 1 Hz activity occurring every second. This is a case of patient who had a CJD. And this is the MRI, the cortical ribbing, the hockey stick sign, the hyperintensities of basal ganglia showing diffusion restriction. Again, this is LPD, this is not generalized periodic discharge. Why? Because they are synchronous and always the amplitude is higher on the left side as compared to the right side. Although we can see some activity on the right side also. And this is a case of GBM. This patient had GBM, and this is the EEG. Many times we see a patient with brain dead, although EEG is not very much required to confirm a brain dead. This is a very important paper by ACNS in which they have very nicely described how should it be done. How should a patient with brain dead, how should we record EEG in those cases? This is a patient of electrocerebral inactivity. Some of the things which to be kept in the mind is, so normally you would see that here sensitivity is 7, but to call it as a brain dead, you should increase the sensitivity to the 2 microvolt, and it should be recorded at least for 30 minutes. There should be no reactivity. By no reactivity, I mean there should be no change in the background activity. It should remain flat. It should remain flat even after intense somatosensory or photic or auditory stimulation. And normally this is the bipolar longitudinal montage. So in the bipolar longitudinal montage, distance between two electrodes they are usually between somewhere between 6 to 6.5 centimeter. But if you are recording brain dead protocol, you have to increase the distance to somewhere between at least the 10 distance between the electrodes to be 10 centimeter. So one thing what you can do, you can create your own montage. You can have to skip that, like you can connect F2 to C4, C4 to O2, F to FP1 to C3, C3 to O1, like that. And you should check the impedance of the electrode also. It should be more than 100 and less than 10 kilo ohm. And the recording time should be at least 30 minutes. And if in case of any if you are not sure, you should always repeat the test. This is very important score. This is a validated score, which is called 2HELP S2B score. What is the importance of this score? This is based on 5 EEG finding and 1 clinical finding. So how do you do that? You have to do 1 hour EEG recording. Then you have to calculate the score. So how do you calculate? So if the frequency is more of the periodic discharges or spike and discharges more than 2 hertz, it gets 1 point. If there are epileptiform discharge present, you get 1 point. If there is lateralized activity, whether be it LPDs or bilateral independent plates, which I showed you, or lateralized delta activity, it gets 1 point. If there is superimposed fast activity, it gets 1 point. If there is a prior seizure history, 1 point. Birds, I will show you in the next slide. If there's birds, then it gets 2 points. So after 1 hour doing, you have to calculate the score. If the score, higher the score, the more chances of having seizures actually. So if the score is 0, then you need not to do like more than 1 hour of recording of EEG. If the score is 1, then you should record at least 12. You should do at least continuous EEG monitoring for 12 hours to record 95% record 95% of the seizures. If the score is more than 1, then you should record at least for 24 hours. And this is a validated score. So what is BIRD? So BIRD is the newly described term. It was described in the ACNS 2021 paper. So it is again focal rhythmic fast activity having frequency of more than 4 hertz, at least 6 wave, which should last 0.5 to more 0.5 or more second and less than 10 second. I will show you the real picture recorded from our lab. You can see over the poster of P4O2 and T6O2. You can see the focal fast activity. It is lasting. It is definitely more than 4 hertz. There are many 6, 7 of poly spike and wave discharges. So it is birds because it is more than 0.5 hertz, more than six activities. So it has got as importance as spike and wave discharges. Actually, it is more important. It is also one of the recently recognized interictal finding. This is the patient who are having frequent visual aura. So we did the EEG, and he described that he was having this kind of aura. He used to have seeing this multicolored object in one of the, and this used to happen every day. I asked him to draw in his mobile. And I took the picture from his mobile. This is the paper which I was talking about, ACNS critical care paper. This is a very nice paper. So in this, they have described everything about the EEG related to the ICU. How do you measure? How do you define? That's the thing. Thank you for your attention.
Thank you, Dr. Vivek. That was an excellent presentation. Like, really loved the details that you went into. And there were a few questions that I had in mind. Meanwhile, yes, the audience can maybe pull up some questions on the chat window. So the few questions and a few points that maybe you can describe more. So one is, yes, that most of the audience will not be knowing about what exactly is a spike, sharp wave, polyspike, etc., etc. So maybe you can just show them once on
Right,
the
sir. Right, sir.
EEGs.
Right. Right, sir.
And another thing was phase reversal. You had mentioned it in one of the initial slides. So maybe
Yes,
phase
sir.
reversal also you can point out.
Right, sir. Right, sir. So this is a bipolar longitudinal montage. So you can see this is the left and this is the right. So whenever we see EEG, we always compare left to the right side. You can see so much of the sharp activity. So this is spike. Why is spike? So spike, sharp, they have some duration. So if that this is the ones basically, if you can see, distance between here to here is 1 second, and this is 200 millisecond. One faint line, if you see, distance from here to here is 200 millisecond. So the spike, the duration of the spike is less than 70 millisecond. If it is more than 70 but less than 200 millisecond, then it is sharp. And if it is more than 200 millisecond, it becomes slow wave. If you see this graph, this is our right temporal chain. So you can see the activity over FP to FP8 channel, which is pointing downward. So why it is pointing downward? That means F8 is more negative as compared to FP2. Okay, so this is a bipolar longitudinal montage. Both are active. That's why it is called bipolar. So F8 is more negative as compared to F8 T4. You can see that almost if you can, like, this is almost flat. So they are similar. They have similar activity. They are straight line, sort of a straight line. That means almost similar. TCC T4 is almost again more or less flat only. So almost equipotential. And if you compare T6O2, it is going up. That means T6 is more negative as compared to O2. So you can see here they are trying to meet, like they are going downward, they are going upward. So the why I told it as a broad as a phase reversal, because it is crossing two channels, F8 T4 and T4 T6. So if we change the montage to the common average montage, so we localize the focus in the bipolar longitudinal montage with the phase reversal, and when we
Okay.
change it to the average montage, we see for this thing amplitude. So I will change it to the common average. So you can see
Okay.
these things is showing the maximum amplitude. So this is the focus.
Okay.
I
So
hope it.
from this, this was a good explanation. Beyond this, one more thing that came to my mind was about the montages. Like, what are the common montages for seizure detection which are used in the ICU? And what is the purpose of, like, bipolar or common average? What is the purpose of each of them?
Yes, sir. So normally, whenever we are reviewing EEG, we should use at least two montages.
Hmm.
So my go-to montages, like most of them, we use bipolar longitudinal montage, and then we confirm in bipolar longitudinal montage. I look for phase reversal. Just now we saw, and then in
Hmm.
the common average, we look for this thing for increased amplitude, highest amplitude to localize the focus. And
Hmm.
when I am doing video EEG, like long-term monitoring, when I am doing, then we have to add several LT1 and T2 electrodes also, and
Hmm.
subtemporal chain also. But that is not required in the ICU.
Okay.
Yes, sir.
So Bharat is asking, is there any minimum number of channels to record continuous EEG?
Sir, yes, sir. We should include all the bipolar long-term channels.
Okay. So
Yes,
basically
sir.
19
21.
channels total.
Yes, sir.
21.
Right, sir. 21.
Okay.
Yes, sir.
21. Okay.
Mm.
Next thing is one point, like this is something that I am speaking out. Like most of the audience, they are used to frequencies associated with EEG as the frequency spectrum, like the delta, alpha, theta, all those, beta, all
Yes, sir.
those, right?
Yes, yes,
But
yes, sir.
I just wanted to point out that the frequencies that you are saying, like more than 2.5 hertz, more than 2 hertz, that is actually the visually appreciated spike frequency rather than the
Right.
frequency spectrum. So these two
Yes,
need
sir.
to be a little bit differentiated, otherwise people get confused.
No, so when I spoke about 2.5, so, I was talking about this graph only. I was not talking about the quantitative EEG monitoring.
Yes, yes, exactly,
Yes,
exactly. So
yes, yes,
quantitative EEG frequency spectrum is different. Here,
different.
for visually differentiating the spikes, you need to look at how many spikes are there per time, basically based on the
Exactly,
bars
sir.
there, right?
Exactly, sir.
Okay.
Exactly.
One more thing, like Bharat, this would be useful for the audience if the important papers that Dr. Vivek spoke about, if we can get the links of them and we can put them in the description of the video.
Yes, sir. Sure, sir.
Yeah.
Definitely, sir, we can try that.
Okay. Dr. Rohini is asking a question.
Yes, sir.
Reason for increased distance between the electrodes in brain death EEG recording?
That's a very good question. So normally, what happens in like a bipolar montage, like here I will show like FP1, F3. It is showing the difference between the two channel. So if the both the electrodes FP1, F3, I will place them very close. So the amplitude difference between them will be not much. But if we increase the distance between the two electrodes,
Hmm.
so the difference, obviously, the potential difference will be high. So that why we are increasing the distance in the bipole, like in the case of brain death, because we don't want to miss even tiniest of the brain potential.
Hmm.
That is the whole idea of increasing the distance.
So whenever we are recording in from of EEG or any sort of electrical potential, always remember that there are two electrodes which make up a channel. Both of them are
Yes, sir.
picking up potentials, right? So whatever you are getting is one channel, one electrode minus the other electrode potential. So if they are too close by, then basically they are picking up almost the same potential, and this minus this will basically negate the amplitude that you are getting. And if you want to record even the smallest of potentials, you need the electrodes to be in very distinct areas. And that is why you increase the distance during brain death, just as Dr.
Yes.
Vivek said.
Right.
One more question by Dr. Rohini. Any role of assessing EEG reactivity in the ICU? Reactivity. And do you
Yes.
do it in any conditions? If yes, how do you do it and what should we see?
Definitely, it's a very good question. So, based on the reactivity, we can grade the encephalopathy mild, moderate, and severe. In the case of mild encephalopathy, we will see reactivity. We can see reactivity to the like eye closure and eye opening. Normally, what happens when we close eyes, then we get and the patient is relaxing, we get a nice alpha response. And when we open the eyes, there is alpha attenuation. That is the one thing. But in the case of the ICU patient, this may not be a very good technique. So, like if we are getting a continuous like slowing, then we give painful stimulus, or sometimes we just shout out the name of the patient that to see that whether the patient is getting alert or not. In the case of triphasic encephalopathy, which I showed. So in those cases also we should always check for that whether in the sleep it is disappearing, and if you are giving the painful stimuli, are the triphasic waves appearing again or not. In the case of moderate and severe encephalopathy, severe encephalopathy, you will not get any reactivity to whatsoever painful stimuli or auditory visual stimuli, and in the case of brain death also.
Okay.
So
So,
as the brain gets sicker, the reactivity and the state change, they become less pronounced.
okay. So for reactivity, are there any specific guidelines that this much increase should happen, or increase in amplitude or increasing frequency of the faster activity? Are there any guidelines around that, or it is just visually you have to appreciate?
Yes, sir. So in that ACNS paper which I was talking about, so they have
Hmm.
clearly mentioned that whenever we are checking reactivity, so
Hmm.
we check for change in amplitude and frequency both. So it could be
Hmm.
either increase in the amplitude or increase in the frequency. Merely the presence of the myogenic artifact won't qualify for, because myogenic is extracerebral activity. But if there is change in the amplitude or frequency, that means there is reactivity.
Okay. Dr. Bharat is asking, in continuous EEG, what measures to ensure the electrodes are continuously in contact? And
Yes, sir.
along with that, a follow-up question like, what type of artifacts do you usually see and what do you do to remove them?
So one thing is, yeah, visually also we can whenever we are seeing the continuous EEG record, we will get to know that electrode has become loose. One very good idea is that when you are doing continuous EEG monitoring, we should always keep checking the impedance of the electrode in between. That is a very good rough idea that will give you about the integrity of the system. So the ACNS, they always say that the impedance should be more than 100, just like I told you in the brain that also it should be more than 100, but it should be less than 10 kilo ohm, but preferably should be less than 5.
Okay, so that's the impedance criteria basically.
Yeah.
Okay, okay. Dr. Rohini is asking how many channels are recommended for brain death determination.
So in that paper which I showed, so they clearly told that we should include all the channels. We should not just put limited number of channels, because sometimes we can get limited suppression because of the brain hemorrhage or any brain like tumor or edema or hydrocephalus. So you should include complete channels.
Okay. Okay. So, is there any amplitude criteria for the movements? Like there will be small movements in the EEG anyway during whatever conditions. Are there any specific amplitude criteria for saying that it is less than this many microvolts, and that's when you say that it is a brain dead type of recording?
Yes, sir. So for bed that they say that you should normally whenever we do EEG monitoring, we record at 7, or in the case of adults, or in the case of pediatrics we record at 10 microvolt per mm. So in
Okay.
the case of brain death, they say that you should record at 2 microvolt per mm. And even when you are recording at 2 microvolt per mm and you are getting a flat record, very
Mhm.
commonly what happens then when you will record at 2 microvolt per mm, you will get lot of artifact. Like you should always connect ECG channel also. You will start getting
Mhm.
ECG because you have increased the sensitivity. So
Yes.
that with practice you will be able to know that no, this is not a brain activity. This is coming from the artifact. This is the artifact which is coming from the ECG, or patient will be connected to a lot of channels. So that
Mhm.
because of that.
Okay. So in
Yes.
the picture that you showed of the brain death EEG, like I saw that towards the end, like 2/3 of the EEG, there was a slight hump type of thing,
Yes, sir. That
like
was
in some
artifact.
of the channels. So that is an artifact, right?
Yes, sir. Yes, sir. Yes, sir.
Okay. So these, I think they come with experience once you keep seeing it
Yes, sir.
regularly,
Yes, sir.
right? Yeah.
Yes, sir.
All right. Are there any more questions? We can continue. We have got 10 more minutes, 8 more minutes. Are there any questions from any of the audience? Okay. I don't think anybody is asking any questions. So thank you, Dr. Vivek. This was an excellent presentation. It was a lot of fun interacting with you, and we learned a lot of new things. I personally learned a lot of new things regarding the types of discharges that can be seen during neurocritical care settings in various seizure scenarios. And especially the case presentations were really nice to listen to. And thank you again. Bharat, any last words?
I would like to thank Dr. Dhritiman also for moderating this
Yes,
session
sir.
on behalf of the NCSI team. And Dr. Vivek, it was an excellent practical presentation on how to utilize EEG at bedside in our neurosurgical and neurological disease patients. And
Thanks a lot, sir.
and
Thanks. Thank
just
you
have
so
one
much.
more question. We'll just take
Yes,
that,
sir.
sir.
Hmm. One more question is there. If the patient is normal and follows all instructions, but in the EEG background is low amplitude, what can we do?
Sometimes if the patient is normal, has no focal neurological deficit, if the frequency is normal, sometimes patient may have low amplitude. You should check for impedance. And
Mhm.
in the elderly, it is common. If it is you should check for the impedance. The impedance is coming normal, frequency is normal, reactivity is normal, there is states. You should not worry about that.
Okay, so I guess in these type of cases, one thing is that in older patients, amplitude is anyway going to be low because of the thicker skull.
Yes, sir.
In females also that can happen. Impedance
Yes.
can also cause that. So these things are basically you need to check out. And the important thing is, I think, the
Yes.
reactivity, as you said, right? So
Yes.
common reactivity measures, like Sir had said about closing eyes, opening eyes, seeing the alpha change in the parietal electrodes, and pain will most likely not be required in these cases. Just waking up the patient
Yes,
should be
sir.
enough to get rid of the activity. So I don't think there is anything much more that you need to worry about in these type of patients.
Yes, sir.
I think that answers your question, Mohammed Danish Pasha.
I
Any
think
other
that's about
questions?
it, sir.
Okay.
That's
Okay.
about it, sir. Yeah. Okay.
Okay.
Thank you, sir. I think we will sign off today. And thank you, Dr. Vivek, sir. And any last words?
Thanks a lot, sir. Thank you for giving me this opportunity. It was a great fun. So ICU is a very important investigation. You need to be aware when to do ICU EG, in what circumstances, when to suspect NCSC, when to suspect retrographic seizures. Because we see a lot of like patient with stroke, they are not matching the clinical picture, just like I showed. And in those cases, they are having non-convulsive status epilepticus. We should not miss that.
So I would just like to say to the audience that most of us get scared by looking at the EEG because there are a lot of squiggly lines going around and there's a lot of random activity and we are not able to make sense of those. But a qualitative judgment can be made with experience and by learning some of the common patterns. So I hope that this presentation was useful for you to learn about these common patterns, and I hope that you will not shy away from doing EEG in your patients in the ICU, as well as not shy away from interpreting them and discussing with your neurologist friends.
Yes.
Thank
Thank
you
you,
all
everyone.
viewers for joining us today. And we'll end today's lecture now.
Thanks, sir. Thank you.